Welcome to The Explainer. I am absolutely thrilled you're tuning in. Today, we're taking what is usually a super dense, overwhelming pediatric respiratory lecture and flipping it into a highly dynamic, high-yield NCLEX survival guide. If you're prepping for your nursing boards right now, you already know that pediatric airway questions are heavily tested. They really push your critical thinking and prioritization skills. So we're going to strip away all the fluff and just hammer home the core concepts and safety alerts you absolutely must know to pass. Real quick, here's our roadmap for today. We'll hit the ultimate NCLEX trap, pediatric airway core concepts, distress versus respiratory failure, high-yield conditions and mnemonics, a mini NCLEX clinical scenario, and finish up with a rapid-fire NCLEX recap. Let's get right into it. Section 1, the ultimate NCLEX trap. Okay, we're starting immediately with a high-stakes scenario. The boards love this one. Picture this. A child walks through the ER doors. They are sitting completely hunched forward in a tripod position, literally using their arms just to stay propped up. Saliva is actively drooling from their mouth because it hurts way too much to swallow, and their eyes are just wide with sheer, severe anxiety. I mean, they look toxic. So, what is the very first thing the nurse should do? Pause and think about your absolute top priority here. If you said prepare to intubate, you hit the nail on the head. This classic presentation screams acute epiglottitis. And listen, the absolute golden rule of pediatric nursing here is do not look in their throat. Seriously, no tongue blades, no throat cultures, don't even make them cry if you can avoid it. Why? Because any physical intrusion or even just agitation can cause that highly inflamed epiglottis to spasm, which leads to complete, irreversible airway occlusion. Your only priority is keeping that child calm and prepping for emergency intubation. Moving right along to Section 2, Pediatric Airway Core Concepts. To really get why kids crash so fast, we have to look at the baseline problem. A child's airway isn't just some miniature version of an adult's. It's fundamentally different. It's significantly shorter and much, much narrower. Because that starting diameter is so incredibly small, it takes way less inflammation or mucus to completely block it off. Think about it. A millimeter of swelling in an adult? Kind of a nuisance. A millimeter of swelling in an infant? That's a literal life-threatening emergency. And it gets trickier because of these structural differences. A child's lung volume is strictly proportional to their chest size. But at the exact same time, infants and young children have this incredibly high metabolic and oxygen demand. They burn through oxygen so much faster than we do. So you've got a narrow airway, a tiny lung volume, and a massive demand for oxygen. This is exactly why pediatric patients decompensate so astonishingly fast. They just don't have the physiological reserves to fight respiratory distress for very long. All right, Section 3, distress versus respiratory failure. Pattern recognition is your best friend here. Let's talk distress versus failure. With distress, the child is fighting. You'll see cachypnea, some nasal flaring, maybe mild intercostal retractions. They might have a fast heart rate, but they can still speak in full sentences or at least cry strongly. Now, respiratory failure? That's when the child is losing the battle. They go from being anxious to extremely irritable, or worse, completely lethargic. You're going to hear expiratory grunting, which is the body literally forcing the alveoli to stay open. You'll see seesaw respirations, where the chest and belly move in opposite directions, and head bobbing with every single breath. If a test question mentions grunting or seesaw breathing, you are definitely in the failure zone. And keep a close eye on severe hypoxemia. It's not just low oxygen, it's low oxygen in the blood that stays low even when you're giving them supplemental oxygen. Imagine you've got a mask on a kid cranking 100% O2, and their sats are still tanking. That is a massive flashing red flag for impending respiratory failure. It means the alveoli are just flat out failing to exchange gas. You also have to master adventitious breath sounds. Chunking these sounds by their underlying pathology will absolutely save you on multiple choice questions. If you hear fine crackles, like the sound of hair rolling between your fingers, that means air is bubbling through fluid-filled alveoli, like with pneumonia. Snoring, low-pitched ronchi, air is fighting through thick, gooey secretions. High-pitched inspiratory stridor screams upper airway obstruction. Think croup or epiglottitis. And musical wheezing heard throughout the breath means air is squeezing through tightly constricted bronchioles, the total hallmark of asthma. Link the sound directly to the disease. Section 4, high-yield conditions and mnemonics. Let's get into the specifics. We talked about our clinical trap earlier, but let's give you a rock-solid visual anchor for epiglottitis. The 4 Ds and an S. Drooling, because swallowing is agonizing. Dysphagia, which literally means difficulty swallowing. Dysphonia, meaning a muffled, frog-like, or totally absent voice. Distressed inspiratory air movement. And finally, stridor. This is the most serious croup syndrome out there. Like we said, it progresses abruptly to total occlusion, so hands off that airway. Switching gears to asthma pharmacology. The NCLEX absolutely loves to test if you know which inhaler a patient should use, and exactly when to use it. Always remember this rule. SABA, your short-acting beta-2 agonist, like albuterol, these are your emergency rescue meds. They jump in for rapid relief to pop open that narrowed airway during an acute attack. LABA, your long-acting beta-2 agonists, those are taken daily to prevent the exacerbations from even starting. Never, ever give a LABA as a rescue medication during an acute asthma attack. Next up, cystic fibrosis. Now, it is absolutely vital to understand that CF isn't just a lung problem. It's an autosomal recessive disorder caused by a mutation on chromosome 7. This mutation completely messes with the exocrine glands, creating immensely thick, sticky, concrete-like mucus across the entire body. Sure, it blocks the airways, but it also clogs up the pancreatic ducts so digestive enzymes can't reach the gut, and it alters the sweat glands on the skin. It really is a multi-system issue. Because CF affects those sweat glands, the gold standard for diagnosis is the sweat chloride test. You need to commit this exact number to memory right now. Greater than 60 milliequivalents per liter. If a kid has a sweat chloride concentration of greater than 60 on 2 separate occasions, boom, that confirms a cystic fibrosis diagnosis. Anything over 50 is pretty suspicious, but 60 is your official diagnostic threshold. So how do we manage all those thick secretions? Vest therapy. This is a crucial part of chest physiotherapy. It's an oscillating wrap that goes around the chest, using air pressure to rapidly inflate and deflate. It acts just like manual percussion, violently but safely shaking that thick mucus loose from the deep alveolar periphery so it can travel up into the larger airways to eventually be coughed or suctioned right out. Let's pause for Section 5, a mini NCLEX clinical scenario. Test your retention here. Read between the lines of these symptoms with me. You've got a child having paroxysmal, meaning sudden, violent, and uncontrollable coughing attacks. They happen mostly at night. The coughing is so intense that the child literally vomits afterward, which is what we call post-tussive emesis, and they're left completely, utterly exhausted. What highly contagious bacterial infection gives us this exact presentation, and how do we prevent it? The answer is pertussis, better known as whooping cough. Those brutal nighttime coughing fits are the classic giveaway. And that brings us to prevention, which is super heavily tested. Pertussis is prevented by the DTaP vaccine for infants and kids under 6, and the Tdap booster for anyone 7 and older. Now, why are the boosters such a big deal? Because immunity from these vaccines actually wanes after about 4 years, which is exactly why vaccination schedules show up on the NCLEX so often. Okay, we made it to Section 6, the rapid-fire NCLEX recap. Grab your pens. These are the absolute core concepts to lock down before test day. 1. Epicolitis means do not inspect the throat, keep them calm, and prep to intubate. 2. Asthma pharmacology. SABA is your acute rescue, LABA is your daily prevention. 3. A sweat chloride test greater than 60 milliequivalents per liter confirms cystic fibrosis. And 4. Do not mix up distress and failure. Grunting, seesaw breathing, and extreme lethargy are your immediate red flags for respiratory failure. Always remember, because of their uniquely narrow anatomy and super high metabolic demands, a pediatric patient's respiratory status can flip from simple distress to catastrophic failure in a matter of minutes. When you're staring down a tough question and you are in doubt, ask yourself, which action protects this fragile airway first? Will you be ready to intervene when that monitor alarms? Thank you so much for hanging out with me for this explainer. Keep studying smart, trust your pattern recognition, and what do you say we conquer some more topics next time? See you then.